You've probably heard this before, right? That there's a link between obesity in women and issues with their menstrual cycle, fertility challenges. And for a long, long time, the medical world thought the diagnosis was pretty straightforward. But what if that story, the one we've all been told, is missing a huge piece of the puzzle? Let's dive in and uncover what's really going on. And look, the stakes here are incredibly high. We're talking about research showing that for women with a high body mass index, BMI, the risk of menstrual problems just skyrockets. And get this, for women with a BMI over 60, that risk can jump to over 60%. That's huge. So this isn't some minor thing. It's a massive health issue, and it's wrapped up in a really complex hormonal mystery. So that brings us to the big question, doesn't it? Is the cause always what we think it is? See, when a woman with obesity comes in with these kinds of symptoms, the finger almost always points to one particular condition. But what if I told you that new research is suggesting the usual suspect might not always be the one to blame? All right, so let's start our investigation. We're diving into the PCOS puzzle. Okay, so what is polycystic ovary syndrome, or PCOS? Well, it's the single most common hormonal disorder for women of reproductive age. We're talking about 8 to 13% of women, and it usually shows up as this classic trio of symptoms: irregular periods, high levels of androgens, those are hormones like testosterone, and sometimes cysts on the ovaries. So you can see why when a patient walks in with that profile, a PCOS diagnosis makes a whole lot of sense. It's the go-to. Okay, but here's where it gets really interesting. This is a critical clue. In lean women who have PCOS, there's this classic hormonal fingerprint, right? Their levels of a key hormone called luteinizing hormone, or LH for short, are typically high. Now, LH is a huge player in managing the menstrual cycle, so having high LH is a classic sign of PCOS. Definitely hang on to that fact, high LH, because it's about to become super important. And here comes the twist. Just look at this quote from the research. It says that when you look at women with obesity, even those who have a PCOS diagnosis, their LH levels are often reduced. Wait, what? Not high, but low. That completely flies in the face of the classic PCOS profile we just talked about. This is the smoking gun, right here. It's telling us that there has to be something else going on, a totally different mechanism at work. All right, a new suspect has entered the chat. This big contradiction points us toward a completely new idea, a condition that researchers think might need its own separate diagnosis: FOSH. So to wrap our heads around FOSH, it actually helps to look at what happens in men. There's this condition that's already well known and understood called MOSH. That's male obesity-related secondary hypogonadism. It's a mouthful, I know. But hypogonadism just means the sex glands aren't producing enough hormones. So in simple terms, extra body fat messes with the brain's signals to the testes, and that causes low testosterone. The important thing here is that we already know that obesity can directly mess with reproductive hormones. Okay, so if that happens in men, researchers are now proposing the female equivalent, FOSH, or female obesity-related secondary hypogonadism. The idea is basically the same. Obesity itself is directly shutting down the hormonal signals from the brain, but this time to the ovaries. And this leads to all those reproductive problems we've been talking about, but, and this is the key part, in a way that is totally separate from PCOS. But this is where things get really wild. Look at this comparison. There's a huge paradox here. Both MOSH and FOSH seem to be caused by obesity messing with brain signals, right? But they have the opposite effect on androgens. In men with MOSH, it causes low testosterone, but in women with FOSH, it's linked to high androgens. And that difference right there is probably why FOSH has been hiding in plain sight for so long. It gets mistaken for PCOS because of those high androgens. So, the million-dollar question: how do you tell them apart? Well, we have to look closer at the evidence. We need to examine the hormonal fingerprints. And remember our old friend LH, luteinizing hormone? The key clue is all about how it gets released. So your brain doesn't just send out a steady stream of it. It sends it out in little bursts, or pulses. And the size and the rhythm of those pulses, that's where we find the answer. This chart just lays it all out perfectly. Check this out. Studies have found that in women with obesity, the strength of those LH pulses, what scientists call the amplitude, is cut by more than half compared to lean women, more than 50%. So the signal from the brain is getting way, way weaker. It's not that it's pulsing less often, it's that each individual pulse is just a whisper instead of a shout. And here's the visual proof, side by side. On the left, that's your classic PCOS in a lean woman. The hormone signals are firing fast, they're firing strong, and you get high LH.
But on the right, that's what we think is FOSH. The signals are being squashed, they're suppressed, and you get low LH. I mean, look at them. These are two completely different hormonal worlds, even if, on the surface, they can cause some of the same symptoms.
Okay, so we've seen the evidence. We have the fingerprints. But the question is why? What's the motive? Let's dig into the mechanisms behind this hormonal shift. You can think of this diagram like our investigation board at police headquarters. It shows us that this isn't a simple case with one bad guy. Nope. FOSH seems to be caused by this whole network of factors, and they all lead back to one source: excess fat tissue. We're talking about things like hormone resistance, inflammation, even the speed at which hormones are flushed out of the body. It's complicated. So let's zoom in on one of the main culprits here: leptin resistance. Here's how it works. First, fat tissue pumps out tons of a hormone called leptin. Leptin is supposed to tell your brain, hey, we're full, stop eating. But then, the brain gets bombarded with so much leptin all the time that it just starts to ignore it. It becomes resistant. It's kind of like a fire alarm that's always going off. Eventually, you just tune it out. And that resistance messes with the brain's release of the master reproductive hormone, GnRH. And when GnRH gets messed up, boom, you get those weak little LH pulses we were just looking at. But wait, there's more. It's not just leptin. You've got other factors jumping into the mix. Insulin resistance can also make the brain less responsive. Then you have this constant low-grade inflammation coming from fat tissue, which can also shut down brain signals. And get this, some research suggests the kidneys might actually get too good at clearing LH from the blood, which just lowers the levels even more. It's like a full-on, multi-front attack on the entire reproductive system. Okay, so we've identified our suspect, we understand the motive. What does this all mean for actually solving the case? You know, in the real world, for real people. Let's talk about what this changes for treatment and diagnosis. You want to know the most powerful piece of evidence for this whole FOSH theory? It's what happens when women lose a significant amount of weight. When that happens, it's like the whole system gets a reset button. Studies on women who have had bariatric surgery are amazing. As they lose weight, all these hormonal problems start to correct themselves. Their cycles often go back to normal, their hormone levels improve. It's strong, strong evidence that FOSH is a direct result of obesity, and maybe, just maybe, it's reversible. So why do we care? Why does splitting these hairs between FOSH and PCOS matter so much? Well, for a few huge reasons. First, it could mean much more accurate diagnoses. Second, it means we can start looking at weight loss not just as good advice, but as a targeted medical treatment for this specific hormonal issue. It also means we stop throwing every woman with obesity and irregular cycles into the same PCOS bucket. And finally, it just gives us a much, much deeper understanding of how a woman's metabolism and reproductive health are so tightly connected. And that leaves us with one last, really important question to think about. If we can get good at untangling FOSH from PCOS, at telling them apart, could we be on the brink of completely revolutionizing care for millions of women, offering them more personal, more effective treatments? It feels like a total shift in how we think about women's health, and it's a shift that's just getting started.